SDSF Live. As you're logging on, please let us know where you're logging on from. I'm Nicole Chen from Houston, Texas. I'm a board member of the Shwachman Diamond Syndrome Foundation. I'm currently in the middle of a tropical storm, hurricane or something right now. So I have on my lovely co-host tonight, Orva, to help me as backup if anything goes down. I have been having some technical issues, so Orva will back me up. But Orva is normally our behind-the-scenes person. We thank her at the end of the shows. Orva is a brand new board member for the SDSF. Orva, can you introduce yourself for those that aren't already friends with you?
Yeah. Hi, guys. So I'm Orva. I'm here from Denver, Colorado. I have 4 kiddos. My 5-year-old is our SDS kiddo. I'm obsessed with animals, and I love helping on the show. So I'm glad to be helping.
Thank you, Orva. You've been such a huge help for our shows. So I normally dress up for the shows, but I had a Rally for Rowan shirt on already today. I don't know if you guys can see. Rowan is an SDS patient that passed away in December 2016. And his birthday, I wear his shirts a lot anyway, but his birthday was the other day, and I was just really emotional about it. And I thought I'd keep it. Actually, I think this might be one of the things we could do. Is just we all own a lot of each other's shirts to support each other. So I really just love it. Maybe we can start wearing each other's shirts as like a shout out to each other. We're continuing the SDSF Camp Live series today. This will be joined by Dr. Garry Tobin. Again, he was on earlier a few months ago, I believe in April. And we'll also have Dr. Andrea Granados. They're both endocrinologists based out of St. Louis, Missouri. Dr. Tobin has been working on a study that highlights the prevalence of diabetes in SDS patients. We'll be talking about updates to the study as well as basic endocrinology needs of an SDS patient. This is a great session to watch if you're new to SDS or maybe see that endocrinology refresh. SDSF is currently funding Dr. Tobin's diabetes study. Thank you also to the SDS Project for their generous support as well. Diabetes can further complicate SDS, so hopefully this study can identify patients moving into diabetes earlier and stop the progression of the disease. Today we do have to give away our new tumbler that is really popular. You can win this tumbler by interacting with the show in any way, liking, sharing, commenting, asking questions. And you could win this really fun tumbler that says SDS Strong, really cool. Again, these shows are public. Please don't ask any personal questions. We upload these shows to YouTube, and then we have subtitles, and you could choose whatever language you want to read the show in, and we will be converting these also into podcasts. So we're really excited about that. So let's get our show started. I want to introduce to you Dr. Tobin. Hi, Dr. Tobin.
Hi, everybody.
Welcome to the show again.
Well, thank you again for having me. Appreciate it.
Hey, Nicole.
Absolutely. Yes.
Hey, we're having a really hard time hearing you. You're really choppy, but I just want to reintroduce Dr. Tobin for everybody that couldn't hear you. We've had him on previously, so thank you, Dr. Tobin, for joining us today.
It's my pleasure again. I appreciate all of you guys and the support you've done for us and the willingness to participate in the clinical study.
Thank you. So do you want to go ahead and jump right in onto your slideshow?
Yeah, I would like to. So Orva, you'll run the slides for me.
Yeah.
But this is going to take the place of what would have happened at Camp Sunshine in regard to introducing some of the endocrinologic defects that we see associated with SDS. And since I'm an endocrinologist and primarily a diabetologist, my focus has been on the diabetes aspect of it. And at the end of this, I hope that you'll be able to understand why we're doing the study, as well as the similarities between SDS and cystic fibrosis. Dr. Granados is an expert in pediatric diabetes, an adult diabetes specialist. We've got you covered from all ends of the spectrum today.
And before we jump in, I'm going to go ahead and have you guys meet Dr. Granados really quickly.
Hi, thank you so much, guys, for having me today. It is a pleasure for me to be here. And yes, as Dr. Tobin said, I'm a pediatric endocrinologist at Washington University, and I have a lot of interest in the patients with SDS.
Thank you for joining us. All right, Dr. Tobin, we're going to go ahead and jump on into yours. Okay, can you see that, Dr. Tobin?
I can see the slides perfectly. That's great.
Awesome.
Okay. Okay, we can go ahead and move on from that slide. We'll move on from this slide. Okay, so quickly, SDS is a rare autosomal recessive disorder. And in 90% of the affected individuals, we know the genetics of the process. It affects ribosomes, which means it affects protein synthesis. And the two organs that are primarily affected by the SDS gene defect is the pancreas and the bone marrow. But as we're learning and as more people are being diagnosed with the syndrome, we're seeing lots of other metabolic problems that are associated with this. And the ribosomal disorders are disorders that are going to affect protein synthesis in multiple organs. So do not be surprised if we find out there are other manifestations that may be developing later on as the affected individuals live longer. We can move on to the next slide. So if you take the SDS gene and you put it into a rat model or a tissue culture model, you can see that the pancreas does not develop correctly, and you lose pancreatic exocrine function, which is the digestive function of the pancreas. But the pancreatic endocrine function, which is where the insulin is made in the body, does not appear to be damaged early on, but is damaged later on. So a 1-year-old rat model, which I'll show you some pictures of, will show a diabetes signal. And we can move on to the next slide. In this slide, what you're going to see, and I'm going to just quickly talk you through it, the dark areas of the slide are the endocrine pancreas, and the areas around it are the exocrine pancreas, where the digestive juices are made. And what we see in this animal model is that the endocrine pancreas is smaller and just not as healthy. Okay, we can move on from there. And this slide is actually quite interesting from someone like me who's interested in glucose metabolism. This is a glucose tolerance test that is done in the animal models. And what you can see is that the black bars show that the glucose goes up higher in the animals with the defect. And again, this confirms what I was trying to say at the beginning of the show, is that the patients who carry the SDS defect, because of the pancreas exocrine defect, are also going to develop a potential endocrine defect. And because it occurs later, it's not necessarily directly related to the genetics of the syndrome itself. It would suggest that if we diagnose this earlier, we could potentially treat it and prevent it. And that's my focus, and that's really the focus of the clinical study. Next slide. So, as I said in the beginning, we don't know a lot about the various defects that occur from an endocrine standpoint in Schwachman Diamond. The Cincinnati Children's Hospital has a registry, and they look back through the registry and try to figure out what things they were seeing reported. And they have both patients with the classic mutation and those patients without the classic mutation. And we'll move on to the next slide. And I'm not sure how easy this is to see, but the defects that are most commonly seen are short stature, bone, and the most common defect is actually a glucose abnormality, which occurred in at least 5 out of the 20 individuals in the study. So 5 out of 20 individuals, you're talking about a 25% incidence of a diabetic or glucose abnormality in this genetic syndrome. Next slide. Despite this, the most up-to-date consensus guideline for the management and treatment of Schwachman Diamond does not even mention these endocrine defects, or specifically do not mention diabetes. And that's something I think that we'll be able to change with the clinical study that the SDS Foundation has graciously supported. Move on to the next slide. So my general belief is that the incidence for glucose abnormalities is greater than 30%, and it will increase as the children with SDS or adults with SDS age. And I think there's going to be other defects that may be part of this, could be genetics as well, from the standpoint of other genetics that they inherited that are similar to type 2 diabetes. But I think when Andrea will talk, she'll tell you more about cystic fibrosis, which is another disorder where the pancreas goes away, but the diabetes occurs later. Next slide. And the potential mechanisms for this, and I think some of these are real, is that when the pancreas is damaged and you can no longer make the appropriate digestive enzymes, I think you'll lose some of the appropriate signaling between different cells in the pancreas. And I think that the crosstalk from the gut to the pancreas and to the brain is messed up as well. And so what we're looking to do with the clinical study is, first of all, figure out the incidence of glucose abnormalities. And secondly, we're trying to figure out possibly what the cause is of those abnormalities. And since this has never been done, this is a descriptive study that we're hoping to perform. Next slide. I think I'll skip this one real quickly, move on to the next one. And one of the tools we're going to use in this study is a continuous glucose monitor that is placed on the upper arm, and it's worn for 14 days. At the end of the 14 days, we'll be able to download that device that's sent back in the mail to us, and we'll be able to report back what the glucoses look like over the 14 days in regard to activity, diet, and et cetera. And we should be able to make the distinction between normal glucose, abnormal glucose, or frank diabetes. Next slide is a video, and I'll turn this back over to Orva.
Sorry, we have to come over here. We have to share a different screen. I'm sorry.
So this slide, this video is ready to start?
I'm sorry, no.
Okay.
Everybody could still hear you, so if you want to go ahead.
I will. So what the video is going to show you is how easy this device is to place. And it's something that we'll be mailing out to those individuals who would like to participate in this study. It goes on 1, 2, 3. It's activated very quickly. And then, as I said, you leave it alone for the next 14 days, and those glucose abnormalities then come to me. Because of the COVID crisis, we also were planning on doing a glucose tolerance test. Oh, are we ready?
Yep.
We'll go ahead and play the video.
And your setup is complete. Now, let's apply the sensor. The Freestyle Libre 14-day sensor kit comes in 2 parts, the sensor applicator and the sensor pack. It also contains an alcohol wipe and product insert. Select the site on the back of your upper arm where you will clean it with the alcohol wipe and let it dry. Peel the lid completely off the sensor pack and unscrew the cap from the sensor applicator. Place the sensor applicator into the open sensor pack and line up the dark mark on the applicator with the mark on the pack. Press down firmly on the sensor applicator until it comes to a stop. Lift the sensor applicator out of the sensor pack. Simply place the sensor applicator over the site you cleaned with the alcohol wipe. Push down firmly until the sensor is in place. Make sure the sensor is secure after application. All that's left is to start the sensor. Just press the blue home button to turn on your reader. Tap Start New Sensor on the screen. An image of a hand holding the reader next to a sensor on the arm will appear. Hold the reader within 1.5 inches of the sensor to scan it. If sounds are turned on, the reader beeps when the sensor has been successfully activated.
Okay, you can stop it. You can stop it now. Okay, so that is all that's involved in putting on the sensor and wearing it. It stays on very nicely because it's got an adhesive. We can go back to, I think there's one more slide that just kind of gives you a picture of what I would see when it comes off, which is all these different glucose readings every 5 minutes that are being recorded in the individual being sensed. These are part of clinical practice that we use all the time. And I really wanted to show you this sensor so that you were familiar with what we're asking you to do in the clinical trial. I think we could flip it over to Andrea if she's ready and can present some information about cystic fibrosis and talk to you a little bit about what a glucose tolerance test is, which is something that we'll be doing within the sensor timing, but also more formally with blood drawing at some point when the COVID crisis is less problematic.
Thank you. Yes,
Andrea.
so can you see my screen now?
Not yet.
Okay.
Is it giving you the option?
And now it is. Okay.
I see a question from Joan Mowry. That can the device be worn any other place other than the arm? I think it can, but I would highly recommend that it be placed on the arm since that's where it's been characterized.
Now you can see my screen?
I can't yet.
Yes? Okay.
Now I can.
Now you can? Okay.
Yes.
And you guys can hear me. Okay. So, well, we know that patients with CF do have a lot of similarities with patients with Shwachman Diamond Syndrome. So in the recent years, in the past 5 years, I've been working on the glucose levels in patients with cystic fibrosis, and there is a lot of literature about how early patients with CF present with glucose abnormalities and actually diabetes. So we know from clinical studies that patients even from infancy, from 3 years of age, patients with cystic fibrosis present with abnormal glucose levels. And prediabetes. And then later on in life, they present with diabetes. Around half of the patients with CF, when they're adults, they have diabetes. So that's very important for us because actually when they start having abnormal glucose levels, they start getting sicker and sicker. So what happens with them is that they start losing a lot of weight. They also, they don't grow well, and we see it in the pediatric clinic a lot. And they also get admitted to the hospital frequently because of the abnormalities in glucoses and diabetes. And also, they have a lot of problems, long problems, which is something that is characteristic of patients with cystic fibrosis. But it is very interesting to know if the similarities with cystic fibrosis in the SDS population include glucose abnormalities. And this is something that, as Dr. Tobin said, we definitely would like to figure it out. So in patients with CF, we screen. So we basically want to detect early on glucose abnormalities. We currently do an oral glucose tolerance test, which I'm going to talk a little bit about, and this is one of our plans in the current study to do this particular test. Why do we do an oral glucose tolerance test? Because we know that when we want to try to detect diabetes, that's actually the best test. The CGM, the continuous glucose monitor that you guys saw right now, the video that you guys watched, it is a great device that we are using a lot in the clinical arena, but actually oral glucose tolerance test is going to tell us more of a complete information that we need in patients with SDS. So in patients with CF, we recommend to do this screening from 10 years and older. Why? Because at 10 years of age is when the incidence of diabetes increases. And we know that during the adolescent years, the prevalence of diabetes is closer to 20%. So it's very, very important for these patients to get that we identify diabetes early on, because we're able to treat and we are able to actually have a positive impact, decrease the risk of hospitalizations, decrease the risk of more sickness, morbidity, and mortality too. So what's the test that we would like to do? And we actually do. We do it in the clinical area, and we do it in the research area. When we want to try to detect diabetes, this is the best test. And we have a lot of experience doing this test, I think, worldwide. An oral glucose tolerance test is basically a 2-hour test. What we would ask you to do, or the patients who decide to participate in the study, is basically to fast overnight around 8 hours. So basically after bedtime, the patient would go to bed and not eat anything else. And in the morning, we would arrange for the patient to come to a local lab, to a clinic, to a hospital, an academic institution. And then the morning of the test, they would come in and have an IV placed. So it would be one poke. And through the IV, we would get a blood sample initially. After that first blood sample, we would ask the patient to have a sugary drink. It tastes pretty good, I think. And then at the 1 hour and the 2 hour, we would get more blood work, but we would obtain that from the IV. So the patient would get poked only once. And after the 2-hour test, the patient would go home, and that would be the end of the test. As I said before, we have a lot of experience with this. We do it in the clinical practice in children from 3 years of age when we suspect diabetes, and in the CF population, we start doing in the research, we also do it from that age. We do in research from 3 years of age and above. And for clinical purposes, we do in patients with CF after 10 years. So I'm going to stop sharing my screen, and we could possibly start the questions now.
Can everyone still hear me?
We have a lot.
Okay. Can everyone still hear me? I want to add in,
Yes.
the glucose tolerance test will be also a part of the time when you're doing the sensor. We just won't be drawing blood, because we'll be monitoring the glucoses remotely through the sensing device. The formal glucose tolerance test that Andrea discussed will also be measuring some other hormones related to the pancreas, so that's why we need the blood work as well. And we're also screening for other hormonal defects in the syndrome as well. So we're trying to be efficient and get as much information as we can when we have someone available for the actual blood draw itself. The sensing part of this study, which is so cool to me, is done at home. You can place the sensor You can do the glucose tolerance test. You can do the mixed meal tolerance test. You can do all the procedures. And then on the back end, Andrea and I can interpret those same way we'd interpret your blood work. So it's a great study.
That video was super helpful. I really thought it was like needles going into the patient. Is it? How does it stick on? Is it like a glue substance or something?
It's just got a little bit of adhesive around it, and if you wanted to, you could put a big Band-Aid over it. You could put a big heart on it. You can put whatever you want. It won't stop the sensor from working.
I thought for sure. For some reason I had like IVIG, like how that goes into a patient. That looks very easy. So I know we talked about this on the last show you were on. I mean, for example, my son swims very often every day. We're in Houston. The patient can carry on with their normal life, right? It could get sweaty. It could be in water.
They can swim too.
Okay.
Yes.
This sounds really exciting. So we want to tell everyone how to join the study. We have a graphic. So here's how to join the study. Hopefully, if anyone has any questions, we have both the doctors on now. Would be a good time to ask. You could also send any private questions you may have over to that email. We'd be happy to help get those answered.
Dr. Tobin, is it only for genetically? Can clinical kids join the research?
Sorry, at this time, we want the population to be as uniform as possible so we can interpret the data. So it'll be genetically only, not clinical diagnosis. But as you can see, if we change the guidelines, we'll be able to get these things done in a more of a clinical fashion.
Right.
So this is not an expensive device. These devices will give information that you can't get any other way. And what we hope to do first and foremost is to find on a more formal basis, what is the incidence of diabetes? When does it show up? And then, as we get more data, this can be a longitudinal process where we can follow them over time. Andrea, you want to talk about what you do every year with the CF patients?
Yeah, we currently see patients 6 years and older. We enroll them in our study, and we do OGTTs, or glucose tolerance tests, and we also place that device that you guys heard of, the continuous glucose monitor. And we looked at all the clinical outcomes as well, and we see, well, if you present with high glucose levels at the different time points during the oral glucose tolerance test, are you at increased risk of having different issues related to your health? Do you have any problems related to exercise or your capacity of function normally, and your quality of life? So there are a lot of things, a lot of clinical outcomes that we look in the CF population and we are interested in. And of course, we want to bring that information, since we know that there are similarities with the SDS population, and bring it and see if we are able to identify first if they have similarities in the abnormal glucose levels, and of course in the future, if we're able to identify that, how can we prevent that from happening, and what to expect in the future as well. And we know that when we try to change things, when we try to improve things like diet, exercise, we improve a lot of these glucose levels, and that's also part of my research right now. I have created an exercise project for these patients, and we are trying to see what happens after they complete this exercise period. And we're seeing really nice preliminary data where we see how a lot of the clinical components in this population changes after that intervention, for instance. So
I'm going to jump in for 1 second. Joan has asked the question twice on the chat line. is what is the advantage to the patient to identify diabetes early? And I'm going to take that real quickly. I think the advantage is that if we know which foods are problematic, we can decrease your risk of stressing the beta cells, which are the insulin-producing cells, and delay the onset of diabetes, which, as one who has to deal with it as you get older, if you get the diabetes by age 70, you have less chance of having the complications of the diabetes. And secondly, the concept of better nutrition and better health overall from the standpoint of infections is really what we think we can do by decreasing the, I think, the secondary development of the insulin defect in your syndrome. Andrea, do you want to add anything to that?
I want to add something about the pediatric population. What we currently see when these patients, in general, any sort of diabetes, you see a decline in weight gain and growth. So I think that's very significant. I think you see it universally when you have even any early defects, patients do not grow well. And so I think that's something that we definitely want to see, we want to prevent from happening. Yes. And as you said before, complications, which we don't typically see in the pediatric side. It's usually seen as adults in their 20s or 30s. But I think growth in general, hospitalizations for any reason, infections, that's something that we see in the pediatric side.
Thank you both so much for all this insight. Not sure we have any other questions, but again, you could send, if you have a private question or you have a concern, you could send it to that email address. Hopefully, we've demystified some of what this project is about. I know I've heard about this project several times now, and I continue to learn how easy it is. I want to thank our guests tonight. Thank you, especially to Orva behind the scenes.
Nicole,
helping me through this.
I want to jump in one more second, Nicole. Thank you.
Yeah, go ahead.
Sure.
Unlike other clinical trials where you don't hear anything about your data, we're almost like a secondary physician. We're going to be sending you all of the results. You'll have an interpretation of the glucoses that will be related to the 14 days of wearing the sensor. And you'll know, based on what your child ate during the week, what the adult ate during the week, which foods are causing troubles. And you're going to be able to make some decisions. I may not be able to tell you exactly how to help them, but if you can decrease the stress on the insulin-producing cells, you can make them live longer. That's my theory. That's my hope. And we will give you all the data. We'll aggregate it and present it eventually, but you're going to get information that's going to be helpful to you. And if I say it's all normal, you can bless yourself and say it's normal.
Mm-hmm.
Go ahead, Nicole.
Yes, thank you both. I think I jinxed myself. I mentioned my son. How about baby? Of course he's naked tonight. Roman, go back. Okay. Thank you to both our guests. Hold on, let me just hold on. Okay, hold on. Roman,
Hi guys, I just want to remind you guys about our giveaway. So we're going ahead and giving away the SDS tumbler. So if you guys interact with the show, comment, share, you guys are eligible to go ahead and win one of our tumblers. And then I was asked to also share with you the story of Jessica, one of our SDS patients who has who is looking for her bone marrow match. So I'm going to go ahead and show that. Nicole, are you back with us? Nicole? Nicole? All right, so if anybody's not a member of the bone marrow registry, we're asking that if you are eligible to go ahead and text to see if you guys could be a match for Jessica, who is looking for her match. We would greatly appreciate it. And then again, we just wanted to thank you guys for joining us today. Sorry for all the technical difficulties. And then a thank you to everybody who helped make this possible. Thank you guys. Stay safe.
Thank you so much for having us.